Thank you, sir. Following Professor Shoaib, we have Dr. Rashid Mazhar, who is a highly accomplished senior consultant thoracic surgeon at Hamad Medical Center in Doha. He graduated from Dow Medical College and he obtained MCPS and FCPS certifications in surgery, and further he pursued his surgical fellowships in the UK. He received prestigious awards for his exceptional achievements, including the Hamad Medical Center Innovation Awards and Star of Excellence Awards. He has over 40 publications, and he is working as an honorary professor of thoracic surgery at SIUT as well. He holds a prestigious position of director of ATLS course at ERC Qatar chapter, and he will be giving two presentations: state of the art in rib fixation and novel methods of wedge rib fixation. Sorry, can I please have
Assalamu alaikum. It's an absolute joy to be here, and thank you very much, Dr. Fiza, for making it a possibility. It's a little bit humbling to come after natural, forceful speakers like Babar Hassan here. And I would say to Professor Shoaib, who mentioned the first murder, that yes, the good Habil was killed, and we are all children of remaining Qabil. So man-inflicted injuries will remain to come. So trauma will be here. So let's quickly start. I am filling in for my good friend, Dr. Talat Chokhtai, who unfortunately could not attend. A week before this conference, he had to rush back to Toronto because his father was in ICU, and 2 days ago, he unfortunately passed away. So, अब मैं आधे घंटे की समय खराशी नहीं करूँगा. I will try and save as much time as possible. And I have been warned about this, that this is a ladylike, it doesn't follow what you say. So it is not following. Somebody can help me, please. How does it work? Could you now? So this is an old problem. Not even he can do it. So this is an old problem, and we are revisiting. And yeah. So this is the place where I work. This is a truly international group of, these are our 4 senior core members. As you can see from the very side, there's Dr. Jasim, who is a Qatari, who is German trained, then me, who is from Pakistan and British trained, then Professor Takahiro Oto, who is Japanese, also trained in Australia, and the last is Dr. Talat Chokhtai, who is a born and brought up and educated, trained in Canada. So we have and you will see that, you will notice that Dr. Muslim, Muhammad Muslim, and Dr. Manzoor are not here because they are joined a little later. So we have a truly international spectrum of seeing things around here. Now this is an amazing picture. This is for my friend Dr. Talat. This is his father who just passed away. Dr. Talat is a thoracic surgeon, his son of a thoracic surgeon. This is Dr. Saeed Chokhtai, who practiced all his life cardiothoracic surgery in Canada, and his father and son operating together. So that's a vision to be cherished. Now, before I used to say I only have conflict of opinions with people. Now I have some conflict of interest. So this will be, there's something, a patent which is going on, and let's talk about research when we say. I always think that research should be mentioned, come on guys, with a little hyphen. So when somebody talks about research, I say, what have you lost? What are you again searching for? Because human problems have remained the same. People have come up with answers. Times and technologies have changed. So you try and create new solutions to the same old problem, and that's why it should be a research. Now, this is the knowledge of river. I'm happy that my colleagues are not here because they would be bored with this slide. I keep showing it. This is a flowing river which is coming from the bottom and going up. And you see that's the past, that's the present, and that's where a paradigm shift happens and it goes into the future. We are standing on the bank and we are only taking a snapshot. So unless you understand where it is coming from and where it is turning, and if you have some vision that yes, this is the direction it will go, then your packet of information is complete. Otherwise, it is in isolation. So my talk here is about the ribs. When do we fix it? How many need, how to fix that? And I will just take you a visual tour. And why the current solution is suboptimal and how can we make it optimal. So there will be an underpinning of methodology of innovation and creating your own solutions. So this is really difficult. Okay, how many ribs need to be broken to fix? Well, we all can say the more the merrier. The need, and this is all existing packet of information. So most of you would know that fractured ribs themselves do not kill unless they turn into a penetrating injury. The problem is with the ventilatory breakdown is the respiratory breakdown, the compromise of that. Now, per se, the ribs would be less than 0.5%, but the older the patient gets, the more the number of the ribs get fractured, the mortality increases. If you do conservative management, there are studies, and these 2 studies I can provide to you with 200 and 400 patients, also a bit older, but they say that there are, even after 2 years, the patients are suffering. The surgical fixation, we all know that if there is a flail chest and it is respiratory-wise compromising, you do fix that. Isolated, non-flail rib injuries, the jury is out. Nobody knows the answer. There is, at the moment, a fixed con study running in Netherlands, which is doing a double-controlled study on exactly that question, shall we be fixing isolated rib fractures which are not flail? The consensus is building towards that kind of opinion. So this is one study, although it is not very new, but it is American trauma database, more than 64,000 rib fractures, which we knew that 10% of the accidents are causing rib fractures. And when you look deeply, maybe up till half of them had rib fractures, which are not shown on plain x-rays. And that showed that increasing number is going to increase. But this is a very interesting slide, that you see even a single fracture in a multivariate analysis fixing all the variables still had an unbelievable number of mortality, more than 5%. That surprised me. Anyway, the reality check is that we say to our patients that your operation is high risk when you say it's more than 5% mortality. And for example, cabbage is somewhere, the numbers are known. So how do we address this issue of rib fixation? Now I will here jump into the role which Dr. Talat was supposed to do. The twin role was that the Talat would present the state of the art, and I will say a few things about how it can be moved into future with some novel solutions. So a visual tour. All of you have seen these pictures, how the ribs were being historically managed. Okay, no need to go into that. Then what happened is the companies came in. Doctors, surgeons used to make their own solutions. Then the companies came in, and companies hired engineers and say, listen, I want a solution to fix the ribs. They are very clever people. They said, aye, sir, there we go. So they started making fancy geometrical drawings, vector analyses, their methodology of testing things, we don't understand a bit of that, and then they came out with a solution which is imposed on us today. Now, that's the solution today we are doing. These are various kinds of, I'm not representing any company. In fact, this conference was not funded by any of them or supported by any, so we should not be talking about them either. So there are various kinds of solutions, but all of them are largely open fixation method, and they are maximally invasive. You will go, and if you Google minimally invasive methods of rib fixation, then you will get people who will say, yes, I do minimally invasive. But you look at this picture, look at the undermining, look at the pulling and pushing and retracting. This is really minimally invasive? I would say no. This is just misusing the terminology. So this is where we are standing. This is one of those which we use quite common. And the steps I will just tell you, that you measure the thickness of the rib. Now the mantra, the Bible of these engineers was, that they were told by the doctors, do not go through and through the rib, because under lies the lung and the pleura, and you will get a pneumothorax. So what they started doing is a philosophy of monocortical fixation. I will go through the outer cortex, I will engage whatever frictional tool is to be engaged to fix my plate or conduit, and that will be on the outer cortex. So first thing, you measure the thickness by either the broken end or from the top end. Once you measure the end, then they have this contour measuring thing, the yellow one. So you make the contour with that. Then you pick up a plate which is already pre-contoured to that. Now please keep noting down the number of instruments. So you got this caliper, you got this universal plate, then you got the plate. Keep counting, 3. Then once you have done that, then you hold that the pre-contoured plate, and then you have the drill bit protector, so number 4 instrument. Then you choose the drill bit, number 5 instrument. Then you drill the hole, and then you double check that the hole is in the correct length and dimension, so number 6 instrument, or is it 5? Then you have the set of all these various screws. Then you measure the screw 2 millimeter, you give to the thickness of the plate, and then you do 3 on either side. Looks beautiful. That's the last picture you guys see. Now all these instruments we import. When they cost us a hell lot, arm and a leg, then we think, why does it cost so much? Because if it was made by a European or an American worker, the cost of this product includes the salary of the European and the American worker, the pub drinks bill in the evening, the holidays bill once a year, his pension in that, and his divorce bill is all included in that by the CEO. And that's why you pay all of that. Great? So this is the usual picture you see. Now something ought to change, because we can't carry on like this, being a true and total importer of technology. So I will get on with that. There are 3 words which I want youngsters to learn: pain, gain, current art. Current art is the current science, the position of anything. Pain is the problem with that, or anything, or any issue. And gain is how do you reverse that into a new innovative solution. So the approach at the moment of rib fixation, you can see that you are converting a closed fracture into an open fracture. That defies in the face of our principles. You have the parts, there are others which have clasping parts, they impinge on the intercostal nerves. Further, and you leave a metallic shadow or multiple metallic shadow all their lives, so plain X-ray will not pick up a small nodule few years down the line. And these are complex instrumentation which cost a lot. And I've already explained why do they cost a lot. So that was the pain where we started to create a gain. And the gain always starts with an idealized theoretical solution. So I set up with an open mind, what would be then an ideal rib fixation system? So I must have a truly minimal access solution. I must have no percutaneous access. I don't want to penetrate the skin on top of a fractured bone. Then I should have no impingement on the intercostal nerves. And it should be ergonomic, very easy. And it should be very cheap. It should not cast any shadows. So I thought that that is an ideal wish list. And if we can do that, that will be something interesting. So the thought. And then what I call another word which I need to have to the youngsters, how do you innovate something? You use a method of reductive analysis. These are my understandings. There are colleagues who can give you better understanding of these things. But you do take the problem, act like a child, and keep asking why, and keep asking why, and keep asking why, until you are like that Greek who coined the term atom when he did not have even a magnifying lens, and you reach to the bottom point. So, and once you have gone to the minimum there, then you do constructive synthesis, and then you make your own new solution. So we came up with this rib clasper strapper system, which is as near to the idealized, and I'll just walk you through the process, will not take too long. So this was the fractured rib. What are we trying to achieve? This is reductive analysis. We need to reduce that. Fine, that's easy. We know how to do that. And then we need two buffer or buttresses on both sides, and we need to hold them. The red was the no-go zone to the engineers, which created all that complex problem. To us, maybe not that much. So once you have these two things, that's what the engineers did for the monocortical drilling. And I've already explained to you, they did not want to go down, so they only stayed onto the brown outer plate. But now, if you do a simplified thinking, and I'll come back to the two plates on either side which need to be compressed together. I don't want to put in a screw in there because that leads to the same old problems. So I need forces from one side, and I need the bridge on the top so that it does not go up in a vertical direction. But then you look at the white thing, do I need all those areas? So now I can get away with just clip-like thing. Fair enough. So forget the white, now the blue clip is there. How do I hold it? If I do the same, it's already invented. There's nothing new. Now, the cardiac surgeons would know this ingenious device, the Star Edward valve. And I'm of that generation who have used that. And the most lateral thinking in that is that the manufacturing is done with the ball and the cage, comes separately in packet, and a psilastic ball comes in a separate packet. Once you have stitched the valve into the aorta, you squeeze the psilastic valve in there because the flow will always be, force of direction will always be up and down, never sideways. So taking that from there, we said, okay, if we make it of a material which can be molded and which can have enough potential energy to grasp the ribs against a plate on the inside, then we have achieved our target. We got the material, we got the engineering, and we got some 3D printing, we got the, I'm happy to tell you that the prototype, first prototype was developed here in Karachi, in Korangi. And then you have an ex vivo set of experiments. You do simple clips, and you do clips which can lock onto each other like a train bogie, and then you have the solution. So I think I will stop here, and you can think of fractured ribs, or you can think of value-added ribs, depending on how hungry you are. Okay? Thank you very much.